Join our incredible moms who have mastered the art of balancing motherhood in today's episode of We Time Convo.
My name is Debbie.
This is Liza.
Moms sharing inspiring stories, practical tips, and a few hilarious anecdotes. And it all begins now.
We Time Convo. Thank you for listening. This is Liza. I am hosting solo today. Debbie is out of town celebrating her husband Peter's birthday. So birthday shout out to Peter, and we miss you, Debbie. So today we have two very special guests. We are going to be discussing family planning, infertility, fertility and we have a repeat guest here today. Dr. Bovone's in the home. Can I call you the Queen of Down Under or no?
Oh my God.
Are we not that cool yet?
That's a good name. Yeah. Sure, I'll take it. Yes.
And then we also have super repeat guest, Marita.
Yay.
Thanks for having me again.
So thank you both for coming on.
You're welcome.
So I guess I have a bunch of questions for you, Dr. Bovone. One of them is, what is infertility?
Well, the definition of infertility would be when a couple is trying to conceive. And if the woman is less than 35, we would say that after trying for a year of trying to get pregnant and they're not pregnant, that would be infertility. For someone over 35, it's 6 months of trying.
Do you call them a geriatric pregnancy? Because that's what my doctor called mine. Yeah.
Oh,
They didn't use that word, did they?
Yeah, she called it geriatric pregnancy. I was 38.
Yeah, no, we do still use advanced maternal age, which would be over 35. It may show up as coding as geriatric. I don't know, but it shows up as advanced maternal age, which does increase the chances of infertility. And that's why it's that shorter window for diagnosis. And because a woman is only born with so many eggs, and then over our lifetime, those eggs will dwindle. And then not only is the number getting lower, but also the quality of the eggs. We'll see a dip, especially in like the kind of mid 30s, we'll see that. But no, definitely I bring up with patients anytime as in their kind of 30s of just, even if they're not in a relationship, of just what are their goals in terms of like, do they want children? Do they not want children? I want to be respectful. If someone doesn't want children, I'll make a note of that. So I'm not asking them every visit. And if they do want kids, and it's that discussion of when. And we do know that with that decrease in egg quantity and quality, that it might be something to consider egg freezing for if you're going to delay having a family. So I try to bring that up with every patient, in their 30s or so, just to find out where they're at so we can educate.
So is it more, so if a couple were trying to have a baby, is it more on the female than the male?
It's actually both. Yeah. So we always say it's never one person's issue. It's a couple issue. So I try to approach it that way. So as we're evaluating the women with basic tests is what I would do, is just a general OBGYN. So I'm not a reproductive endocrinologist, is a specialist in infertility, but I can usually start that conversation, getting some lab work and some ultrasounds. At the same time, I recommend the husband to start with a semen analysis. I'll also ask his, general medical history. Is he on medications? Smoking, drinking, drug use, all of those things can impact male fertility as well.
And Marita, I think you mentioned that you were having you had infertility issues.
Yes.
Yeah. So let's hear your story.
Pretty much, yes. So according to Suzanne's definition, then I would have been considered infertile. We got married when I was 28, and I'd say about 30 to 31, we started trying to have a kid, and it was over a year. So we weren't getting pregnant, and actually it was very frustrating, emotional time for me, because I thought, what's wrong with me? Why is it, that's my immediate reaction. And so I had a great OBGYN through Kaiser, and they were the ones that recommended that, well, let's just do some tests, exactly what Suzanne suggested. I got tested, my husband got tested. And what came back was that, I'm barely remembering this because my kids are in their teens and 20s almost. Basically, I had a hostile womb. And so it was like they
was it angry or
no? It's more like even when their sperm are there, they my body tries to battle the sperm more aggressively, I guess. Then that's the words I remember the doctor telling me. It was a hostile.
I've never heard of that.
Yeah, so it's just I don't know if it has to do with the pH balance of the what it's like in there. I don't know, but we had to have help, and then we were told all the options, and it sounded really scary. And for me, I've always wanted to be a mom. So it was really sort of like frustrating because I was like, how long is it going to take? And then at some point it would get to the point where like my husband might have to give me shots, and he was like, I don't really want to give you shots. And so
what kind of shots are they? Are they hormones?
I think so. I think what it was is that we would, it's been so long, I got to remember. So I just know that we had to like check when I was ovulating, and then he had to, because we needed help, I was taking Clomid, I think Clomid, right?
Yeah.
So Clomid is what I was taking to help, I guess, increase the number of eggs that are released so they can get fertilized. And then we were supposed to just basically have sex like normal. But then I would also go into the doctor's office when I was ovulating so they could give us an extra shot. So my husband would have to create a sample, and then I'd have to go get inseminated in the office. And so
did you do that? So you have 2 kids.
I do have 2 children.
Did you do that same method for both kids?
We had to, yes. Well, I think, to get my first child, we were trying for over a year. And then everyone said, well, you never know, because I'm very sort of negative with that.
It happens when you aren't really trying.
Once you have it, then it's easier. And it wasn't easier. By that, we were thinking we'd spread out the kids by about 2 years. And so I think we were trying for 6 months and nothing happened. And then my OBGYN said, well, you do have a history of infertility. We could just go ahead and get started. And so we did. Same process. And so we have 2 kids now.
You have 2 beautiful kids and one of each.
Yes.
So Dr. Bovone, is infertility a common problem? Are you finding that
It's very common. Yeah. So one of the things as we're talking with patients when they come in and just taking their medical history, and they'll come in oftentimes for a family planning visit, is we'll go over not only their health history, certain medical conditions, medications can interfere or make a high-risk pregnancy. So we want to identify that. And then we also want to look at the menstrual cycle in detail. Not everyone has a perfect 28-day cycle. Some people can, as long as they're able to predict their cycles, then we'll go over the timing of when you're most fertile, which a lot of people don't know. So I always use a 28-day cycle as an example and go over to the calendar in the room and say, okay, if you had your period on August 1st, and then your next period is going to be August 28th, you'll probably ovulate on the 14th. And so that's when the egg is released, and it only lasts for a few hours. So your fertile window is those 5 days before, because sperm can last for up to 5 days. So you want to have more sex during that fertile window. And you could have sex every other day. You don't have to have it every day. And some people, when you tell them that, their eyes just light up and they're like, oh, we were having more sex after ovulation. So then it's just shifting, hopefully, the timing of sex. And then just part of that menstrual history is not only is the cycle regular, because oftentimes it may be irregular, and we want to investigate why. Are there heavy periods, clots, pain? We look into things such as endometriosis and polycystic ovarian syndrome. So we also kind of educate patients who are starting to try to conceive that if we have those definitions of 6 months and 1 year, but if you have a red flag such as polycystic ovarian syndrome, or you're doing ovulation kits and you're not detecting it, do not wait 6 months or a year. Come in sooner, because then we want to take that next step, like Marita was saying, and then consider oftentimes pulling in our reproductive endocrinologist to help.
So how long do you usually give a couple that's actively trying before you start referring them to more of a specialist? Is it a year?
It depends on, are there other underlying conditions that might make them have difficulty? It'd probably be quicker to refer. A lot of patients will self-refer now to the infertility doctors because their insurance allows it. And so they're just self-referring, which is fine. Or we might go over things that we can do. I am comfortable prescribing the ovulation medications and then to induce more eggs, more than 1 egg a month, and then the patient could time their sex. I'm not doing the inseminations in my office. But if patients want to fast track things, I always say it's never harmful to sit down with the fertility doctor, and they will kind of lay everything out and then set a plan with them.
I know that for my daughter, she's my older child, we got close to they were going to say, let's try it for 6 months and see what happens. And then after 6, because I was just orally taking Clomid.
Mm-hmm.
And so I just remember that it got closer to the point where like, okay, if it doesn't work this time or the next time, then, you know, the doctor's going to recommend that we do shots. And my husband was really against shots. I don't know why he just was. And so I was like, well, I don't know. Well, then I'll just give them to myself, the shots to myself kind of thing. And, the doctor was saying that might be harder for you because I don't know why he said, I can't remember, but it was less than 6 months that we got pregnant. And then with my son, the same idea. I think that it seemed like it happened sooner, but we still had to have the infertility help, the Clomid and then keeping track and stuff like that.
So were your pregnancies for both kids fairly like normal?
Yeah.
Fine.
After that it was fine.
No issues.
There are no issues with my pregnancies. No gestational diabetes.
They were born on time.
They were born. My daughter was born right around time. My son was actually born 2 weeks earlier.
So what are options to treat infertility?
So it depends on what the underlying cause is, if you're able to identify it. Probably one of the more common ones that we see is polycystic ovarian syndrome. And the classic patient with PCOS will tend to be overweight. And so probably the first thing we recommend is weight loss may in fact have their ovulation come back, because these are patients who will go many months without a period. And then all of a sudden when they start losing weight, they'll have their period, some conceive, and they're like, we've never used any birth control. How did this happen? We have to point out like, you lost weight. And that's probably what had happened. Easier said than done, though. It's very hard to, I think, when someone's in front of you and they're struggling with getting pregnant, to just say, go lose weight. It's not easy. These patients typically need to follow more of like a lower carb diet. They've probably tried many different things. And so connecting them with nutritionists, and sometimes they will need just medications to help them to ovulate. If we are suspicious of endometriosis, studies have shown doing a laparoscopy and treating the endometriosis, that fertility actually improves after that type of surgery. So again, trying right away. So it really depends on what the underlying issue is. And we always stress kind of as we're trying to get pregnant, optimizing your health and just maintaining healthy weight, blood pressure, lifestyle. For partners, sometimes we identify men. We know that excess weight definitely can impair, sperm production, excessive alcohol, and even marijuana. Probably marijuana is more harmful to sperm than cigarettes. So just again, having both, people in the relationship work on their overall health.
What exactly is PCOS and endometriosis?
Yes. So PCOS is polycystic ovarian syndrome. And there's 3 criteria, and patients have to fulfill like 2 of the criteria. And so one is irregular periods. Another is having an ultrasound that shows polycystic ovaries. It has a certain pattern. The ovaries are slightly larger. And then usually having excess androgens, the male hormones, which will then increase, hair growth, perhaps on the face, the breast, the abdomen, and then acne. And so a lot of people do fall into that category. And so they will need some help oftentimes with getting pregnant. And then endometriosis is where the lining of the uterus, which we call the endometrium, is what grows every month and kind of gets lush and ready for that fertilized, embryo to implant. That tissue somehow gets outside of the uterus. And that can happen, we don't know exactly why. It can happen with retrograde menstruation, with like your period flowing backward through the fallopian tube. It could also happen maybe during development when you were an embryo developing. And so wherever that tissue lands, it can land on the ovary and make an ovarian cyst. It can land on intestines, a bowel. There have been case reports of it land, in the lungs. It's kind of a strange disease in that sense. It could be all over. Some patients typically will have very painful periods. And that usually is painful like right before their period starts. And these are people who are missing work and school. And studies do show that it can take like 7+ years to get a diagnosis. So I think as physicians, we're getting better at talking about it and considering it with our teens that come in, because there is more, diagnosis in teenage populations as well. And I think bringing the issue up, we're not going to jump to, do surgery on young girls just to find out if they have it, that we can also clinically diagnose it by trying to suppress ovulation so that way you're not having periods. If we can kind of control the hormones, that tissue that is outside the uterus won't get stimulated either and grow and cause pain. So usually when people come in and we clinically think it's endometriosis, we can kind of test that theory by suppressing ovulation, using the non-steroidal anti-inflammatory medications such as Motrin. And if someone kind of keeps not having success with those, we might consider a surgical evaluation. There are other more stronger medications geared for endometriosis where you're kind of shutting down all the hormones more significantly, kind of to menopausal levels, which then they'll have those side effects.
Yeah. Is that the same for PCOS? Is that something that you can see in teens, or is that something that usually happens when they're older?
It is in teens. You do have to realize when they first get their period, those first 2 years can be irregular. You don't want to use that 2-year period to like diagnose it because many of them will skip periods and have all of that. But no, we do see it a lot in teens, probably like after that 2-year mark, you can diagnose it. And that's where using that ovarian volume perhaps might be larger. So there are some of the criteria that is expanded with that.
Thank you. So that's all the questions that I have, only because I never had infertility issues. All my kids were, I don't want to say they're accidents, but they weren't planned. So I'm very fertile. So Marita, as a mom that was having infertility issues, what questions would you have for Dr. Bovone that you think listeners that are having the same issue would want to hear?
Well, I think, because I do know the answers to these now, but like what kind of test do we have to anticipate? Because for some reason I remember I had to there was some sort of dye test that they checked something, and what kinds of tests besides a blood test and besides a pelvic exam should someone who is going to be treated for infertility, what kinds of tests should they expect?
So you definitely want to go in and see your physician and make sure you're up to date on all of your just cervical cancer screening, sexually transmitted disease screening, and then having that detailed history taken, because even if you're having regular periods, you may not be ovulating. And so we can either test that with blood tests at a certain time in the menstrual cycle. You could look at the ovaries as well on an ultrasound to see how many eggs are there that have that potential to develop. And then also looking at if people have had procedures on their cervix, such as for treatment for abnormal pap smears, that might cause some scarring. It could change the cervical mucus. So again, diving deeper into the history. The test with the dye that you're referring to would be a hysterosalpingogram. And that's where a radiologist would be putting dye through the cervix into the uterus and out the fallopian tubes. They'll take an x-ray. And so they can see if your tubes are open. Some of the fertility doctors will do that test in their office just under ultrasound with saline, and they'll look for bubbles that can go through the fallopian tubes. So it's a slightly different test, but we know that if your tubes are blocked, that you probably won't be getting pregnant on your own because that's where the egg and the sperm meet. And then if they are blocked, that does potentially increase the chance of having an ectopic pregnancy. So if that sperm and egg met inside there and the tube was damaged, there's little hair-like structures within the fallopian tube that help move the embryo down to the uterus to get implanted. And so if it doesn't move down, then it can then implant within the fallopian tube and have an ectopic pregnancy. So you want to kind of like evaluate each different area of fertility. And likewise, sperm, we're looking at like the motility, the count, what they look like. So all the different parameters of what sperm function looks like. So
when we first started I think we got lucky. We had like sort of, I think the first sort of approach to dealing with fertility. And I just remember like after we had sex, I had to like lay in the bed and I kept my feet up against the wall. Yeah. I don't know how much that helped or not helped. It was just, I just remember having to do that. But I just remember the next step would have been not just the orally taking Clomid, that you'd have to have the shot. What would have been the next step had we not gotten pregnant?
Yeah. Well, it sounds like you were taking Clomid. So the most common ones are Clomid and letrozole. And then the shot that you were referring to is probably what we call an HCG trigger shot. And so that would be given at a certain time so that you can predict when ovulation would happen. So it would help the fertility doctors to know when to tell patients to have sex or to come in for an insemination. So it really hones down on the timing of everything. If you're doing inseminations and that's not working, and usually you'll try things 3 cycles at a time and then kind of move on. The next step would likely have been IVF. So in vitro fertilization, where you are giving yourself more shots throughout the cycle in terms of hyperstimulating the eggs. And then what the physician will do is they will do an egg retrieval with anesthesia. So they go through there's a vaginal probe and a needle on that tip of that probe that they can then remove the eggs from the ovaries. And then in a separate petri dish, they can combine the eggs with the sperm to make embryos. And then we do have that technology today of like egg freezing. So a woman can go through that and just save her eggs for the future and not have to like make the embryos right now.
Does insurance cover all of this? Just out of curiosity.
It is covering it more and more. Definitely, I think with the bigger companies and especially the tech companies, patients may get a lifetime max of 20 or 30,000 or so many cycles. They're kind of partnered with specific fertility physicians through different agencies to kind of like optimize it for the couple. But some people don't have it. And then that could be an out-of-pocket cost of $20,000 to $30,000 just for one cycle, perhaps. And I try to tell patients if they do have some coverage to kind of be wise with it, because going through an insemination cycle could eat up those costs within like 3 cycles. So that's where you want to sit down with the physician and really map out, what is a likelihood of success, and they'll try to give you your best chance, the best options, but being smart about it.
I do want to say that if you are a couple going through infertility, it's really important that you and your partner are communicating what your expectations are, how far you both are willing to go with this process before you decide, okay, we're not going to be able to have children this way. And then what are our other options? So my husband and I had that conversation, like how far how far are we willing to try this? How long are we willing to try this? Fortunately, I had pretty good insurance. So, and I was with Kaiser. So we didn't have to spend thousands and thousands of dollars on this. We just went through Kaiser and paid whatever our copay was. But there was a point where we had to have a conversation. Well, how long are we going to try on our own before we decide this is just not for us? And that maybe we want to consider adoption. So, but it's really stressful when you're in it. And so sometimes I feel like I stressed myself out of certain things. Like I worried too much about it to the point where my husband said, you can't keep worrying about it. It'll happen for us, whether we do it by ourselves or we adopt a child. We're going to be parents somehow. So it's really important that you have those conversations, that you and your partner are on the same page, because if you're not, it can be really stressful. And so I really appreciated my husband said, I don't want to be the one to give you a shot. And so I'm like, okay. So then we knew sort of like, okay, after this, if we have to go to the part where it's a shot, either I'm going to do it myself or we're going to move to the next step, which is IVF.
Yeah. No, it is 100%. I agree with all of that. It's so important, I think, for the couple going through it to have those conversations. And he had kind of had his like line in the sand, but sometimes you have to reassess it and go, okay, this is what you had said before. Are we still there? Because a lot of patients will say, oh, we would never do IVF. And then they get to that crossroad. And then I say, don't just say, oh, go with what you first thought, rediscuss it and talk about it. There are a lot of support groups, whether it's online, a lot of therapists will specialize in infertility, because it is isolating, especially if you're looking at all of your friends having babies, they're on baby number 2, and everyone's like, just relax, have some wine, go on vacation. And when it's not happening to you, it's really hard. So I think always having that communication with your partner is important.
And not letting outside voices affect you. So unfortunately, we had a couple of our friends, and they were uber religious. And so they were passing judgment on us about, well, if it's not God's plan, you shouldn't be doing it that way. And I'm like, I don't really think God cares. I think it's really about what we want to do and what we're comfortable with.
100%. Yeah.
So, but there are people like that, that'll that's what we experience. So like they go, oh, you couldn't do it naturally? I'm like, I don't really know why it matters to you. It's not your kid. Yeah.
So I actually have a fun question. Me and my fun questions. So you know how, some people want a boy or a girl and they say, oh, if you do it doggy style, you get a boy, or you do this and that, or they go buy some Chinese calendar. Do you feel that there's any truth to that, Dr. Bovone and Marita?
No, I don't. I think it's fun to do, but you might end up with 3 boys, 3 girls. There isn't any special food or positions or timing. When you said like after the insemination, like putting your legs up, like people ask like, well, should I sit there and elevate my hips? And, sometimes I'm like, well, jumping up and down doesn't prevent pregnancy. So it's not like that would, automatically work either. If you do want, I think that family balancing, some people look at it that way, then IVF would be another route that you could go through if you wanted.
Tick.
So you can, once you make those embryos, that it is quite common that most couples nowadays will be doing testing on those embryos to look at the chromosomes. And so you can select if you want a boy or a girl, or you could ask your physician to just select for you and to put in the best quality embryo. But that would be another reason to do IVF if you had no issues getting pregnant, but you wanted to like balance your family.
Interesting. I never knew that.
I cannot comment on whether I think what works. What position works better.
Do you think it's more like genetic?
Well, there are with people who do like inseminations in terms of like spinning the sperm, and they might quote you that they're able to, but I think you always have to be prepared. Like it may not work. So I wouldn't go by that. I think the question is, do you want to accept another child into your family? And if you were really wanting one specific sex, then there are ways to guarantee that.
I just love luck of the draw.
All right.
Oh, I did remember reading when I was reading up on it that your fertility does go down significantly once you pass 30, and then it's even more so once you pass 35, and then and then beyond. So that there is a percentage of fertility that you go down. So.
But some women, are diagnosed with, primary ovarian insufficiency. And so that those are women who are going into menopause sooner. Yeah. So it is something to be aware of. And many women will come in and they'll want to test their fertility. And there are, I think, over-the-counter kits that you can buy. And I always tell people, not to waste their money on those, and that we're only going to be doing those fertility tests, maybe looking at the ovarian hormones early in the menstrual cycle and getting an ultrasound if you're ready to conceive now. So getting that testing today doesn't guarantee that you're going to be able to have a baby in 5 years.
Dr. Bovone, I read something about designer babies. They can also high color.
Oh, designer babies. Okay.
The future. So I think that's definitely possible. I guess then there's always like the ethics of what should we be doing. But what one benefit of IVF is for couples who are known carriers of certain genetic diseases, whether it's for cystic fibrosis or another disease that could be life-threatening, that those are the ideal couples to go through IVF because they can test those embryos and only put the ones back in that do not have that gene at all or are just carriers. And that would even be for something like the BRCA, hereditary breast and ovarian cancer gene. If you wanted kind of to eliminate that from your family lineage, that would be one way of doing it. So, but it is kind of crazy the things that you can do. But I think it'll be interesting to see within the field of infertility in terms of like the ethics of all of that.
How far we've come. I'm thinking like they're going to come out wearing Chanel or.
Yeah.
Designer.
I know. Yeah.
Yeah, that's.
I joke that one day they'll be like, this kid's going to go to college, this one won't, this kid's going to have these issues, so you can start like planning before they're even there. But
that's so crazy. The world we live in.
Totally futuristic.
Yeah. Well, thank you guys again for being on, Marita and Dr. Bovone.
Thank you for having me.
Welcome.
And guys, give us a 5-star rating on Apple or Spotify. It helps us a ton. And we will see you next time.